Now we'll see the diseases affecting the white blood cell count. We have been seeing the diseases of the WBC count, both the increased production of red blood cells and the decreased production of our red blood cells. We have seen both. Now similarly we'll see the white blood cells, both the increased production and the decreased production of WBC leads to a disease. So to maintain the normal function or the hormonal equilibrium in our body, every process has to occur on its own pace. Both there should be regulation for production and distribution. Any increase or decrease invariably it leads to a disease. So we know that hematopoietic stem cells, they give rise to this myeloid progenitor and the lymphoid progenitor. Accordingly, the myeloid progenitor gives rise to the platelets and the red blood cells or the erythrocytes. And the lymphoid progenitor, they give rise to the lymphoblast, then they give rise to the lymphocytes, T lymphocytes and the P lymphocytes. So the myeloid progenitor, it is the one which differentiates into the red blood cells, WBC and the platelets. So any defect occurring at any of the points of production of these blood cells, it leads to accumulation of that specific cells. So that gives a picture of a disease. Like we'll see what, like in leukemias especially, there is defect, suppose the myeloblast stage. So the myeloblast doesn't differentiate into the smaller cells, that is the eosinophils, neutrophils, basophils. So there is accumulation of myeloblast stages like that. If the defect is occurring at the monocyte level, the monocytes are not differentiated, then monocytic leukemia is seen. So we'll see in detail what is this. This is just the hematopoietic stem cell process. First we'll see the defect or the decrease in white blood cell counts, what they give rise to. Agranulocytosis. Agranulocytosis, also commonly known as neutropenia. It is a defect of white blood cell count where there is a reduction in the WBC cells. That is nothing but the neutropenia. More commonly among the WBC, we know that among the WBC, basophils, neutrophils, it has a lot of components, the WBC. Here the granulocytes are basically the one which are reduced here. So the reduction in granulocytes is nothing but agranulocytosis. What is the etiology of agranulocytosis? It may be of two types, primary or a secondary granulocytosis. Primary agranulocytosis, it's the etiology is unknown, it is more common in children. The secondary agranulocytosis, the etiology may be some form of infection or ingestion of any drug. More commonly the benzene, the DDT drug, the sulfodioxazone, sulfane drugs and the anti-thyroid drugs or any infections or the anticonvulsant drug. So what happens is this drug, it acts as a hapten, it acts as a foreign body and it induces the antibody production. This antibody production leads to reduction in the number of granulocytes, ultimately leading to agranulocytosis. So the clinical features of agranulocytosis, they are like not of a specific of agranulocytosis. The common symptoms may be seen like appearance of fever, chills, malaise and a sore throat. The characteristic feature of defect in WBC is the lymphadenopathy. Lymphadenopathy is nothing but reduction in the increased swollen lymph glands or the lymph nodes. Okay. So agranulocytosis, it is more commonly seen in middle-aged individuals or adults, and frequently women show a predilection for agranulocytosis. So the general symptoms we have seen. So the skin, how if you see the clinical picture there, the skin is actually pale, it's anemic. As we have seen, the anemia shows characteristic pallor of the skin, right? So that is the appearance of skin. Along with the clinical features and the appearance of skin, the characteristic feature is the lymphadenopathy, the regional lymphadenitis. Whatever those lymph nodes or glands are present, they show the swelling. When you see the oral cavity of a patient affected with agranulocytosis, you see ulcerations of the oral mucosa, the necrotizing ulcerations of oral mucosa, specifically the gingiva, the buccal mucosa, the tonsils, and the pharynx. These necrotizing ulcerations, they are not exudative in nature. There is no proliferation of or liberation of pus or exudate from the necrotizing ulceration. They are just blackish discolorations. They just tends to progress very rapidly. And along with the necrotizing ulcerations, you see there is altered taste sensation in the oral cavity and excessive salivation. And when you see the blood picture, the white blood cell counts are specifically very reduced. They are below 2000 cells per mm². So this amount of reduction in WBC, the individual is more prone for infections of oral cavity or systemic infections. So the peripheral blood picture shows complete absence of granulocytes and reduction in WBC count. The treatment for agranulocytosis is nothing but identifying the causative agent. Suppose the drug Haften, whatever is it has been identified. Then the removal of the drug immediately provides a rapid relief of the symptoms, and the withdrawal of that drug, and accordingly whatever infections are encountered, they have to be just treated. Inflammation has to be taken care of. Because the WBC are reduced, the polymorphonuclear leukocytes are not available for counteracting the inflammatory processes. The necrotizing ulcerations are more common here. Necrotizing, these ulcerations usually they begin as just gingivitis, necrotizing ulcerative gingivitis of oral cavity. Then they progress to ulcerations and they just keeps on spreading rapidly. That is the oral manifestations here. The cyclic neutropenia. Cyclic neutropenia is nothing but a form of agranulocytosis, and these agranulocytosis, it occurs in a periodic fashion, that few of the days the disease is present and few days the disease is just not manifested in the blood picture. So it occurs the periodic cycle. Most commonly cyclic neutropenia shows a periodic fashion of about 3 weeks. Every 3 weeks you just when you take the blood picture, you see the neutropenia is present. So in between you just see that the blood cell counts are normal. So you never know when the clinical manifestations appear. At one point of time, clinical manifestations of neutropenia may be present, and the second day, third, fourth day, immediately the symptoms will be absent. Again, seventh day, again you get to see the neutropenic symptoms. That's why the name has been given as the periodic neutropenia. So periodic or cyclic diminution of polymorphonuclear leukocytes. It is more commonly seen in infants or young children, and males have a predilection for the cyclic neutropenia. Initially, the general symptoms include the fever, malaise, sore throat, and stomatitis. Regional lymphadenopathy is the characteristic feature of WBC cells are decreased, right? And along with that, the cutaneous infection or purplish spots or discoloration of oral mucous membrane may be seen, and appearance of conjunctivitis is also seen. When you see the oral cavity specifically, you see the appearance of a gingivitis, and this gingivitis appears in a periodic fashion. Regularly the patient will be suffering from gingivitis. So first 1 week he'll have gingivitis, next 1 week the disease will regress, the next week again he has symptoms of gingivitis. So such recurring periods of gingivitis, they just the periodontal breakdown occurs. So it leads to loss of the alveolar bone that has been termed as resembling to prepubertal periodontitis. So the loss of, when you see a radiograph or a IUPA, you see there is loss of alveolar bone because of repeated cyclic gingivitis, and that is being given the term prepubertal periodontitis. And when you see the laboratory picture of a cyclic neutropenic patient, as I told you that cyclic neutropenia has a periodic cycle of every 3 weeks. So suppose if you take the blood picture of a patient, the patient has a normal blood count initially for the first 4 to 5 days. After 4 to 5 days, the symptoms of neutropenia, that is a reduction in cells, appear. Then that this state, the complete absence of neutrophils also persists for about 2 days. After that, again for 4 to 5 days, the blood cell counts reach a normal level. Again after 2 days, the cells completely disappear and the polymorphonucleotides become 0 in number. Again after 4 to 5 days, the cells just decrease. That appears in a periodic fashion. And along with that, there is increase in the monocytes also. So that's about the cyclic neutropenia. Cyclic neutropenia, because it has varied manifestations, it is present sometimes, there is nothing of like treatable, it is not treatable like that. So these the neutropenic syndromes are the ones which show reduction in WBC. Now we'll see the commonest or the most severe form, the lethal form, or the blood cancer as it's called commonly, leukemia. Leukemia is characterized by the overproduction of white blood cells. That is, the white blood cell count is highly elevated, and whatever the WBCs are produced excessively, all those are in immature forms. They just tends to accumulate in the blood, peripheral blood, and they just give rise to the symptoms of leukemia. Leukemia, the survival rate is very less in leukemia once affected. The disease, it shows 2 clinical forms. There is the acute form and the chronic form. The acute form is seen in cases of, the acute form shows a survival rate of less than 6 months, whereas chronic form has a survival rate of 1 or 2 years like that. And the acute forms are insidious in onset. Very gradually the patient just shows the clinical signs and symptoms, and the survival rate is also less. This is the chronic form. They take a very long time for the symptoms to appear. The patient may be suffering from the disease for long years, but he may not know that he is suffering. So the patient will be apparently healthy in chronic leukemia. So leukemia, or the increased production of white blood cells, as we have seen the hematopoiesis process, it may affect either the lymphoid progenitor or the myeloid progenitor. We have seen there are 2 series, like the myeloid series and the lymphoid series, right? So if they affect the lymphoid series, then that is nothing but the lymphoid leukemia. It has 2 forms, acute lymphoblastic leukemia and the chronic lymphoblastic leukemia. And the myeloid form, myeloid leukemia, it affects the myeloid series of the production of blood cells, and it has again 2 forms, the acute myeloid leukemia and the chronic myeloid leukemia. So we'll see the differences between the acute and the chronic forms also. Children are more commonly affected in the acute forms, whereas middle-aged or older individuals are affected in the chronic forms of the disease. And leukemia is the disease which males show predilection. Anemias are the disease where females show more of predilection, whereas leukemias are the disease where males are affected more commonly. So just if we see the picture there, it's of a blood cell, hematopoietic stem cell. Okay, it differentiates into the lymphoid stem cells. So these lymphoid stem cells then gives rise to lymphoblast. This lymphoblast normally differentiates into B lymphocyte and T lymphocyte. In leukemia, the lymphoid blast cell is affected. So there is increased production of lymphoblast cells. So the acute lymphoid leukemia develops from lymphoblast cells. Now, if we see the acute myeloid leukemia, as I said, myeloid series is affected. Here, the stem cells differentiate into myeloid stem cells. Then, from the myeloid stem cell, we get myeloblast, and the myeloblast finally differentiates into the monocyte and the granulocyte. So, here the acute myeloid leukemia, it affects the myeloid stem cell and the myeloblast cell. So, more of accumulation of myeloid stem cell and myeloblast cell is seen. So that gives rise to acute myeloid leukemia, accumulation of myeloid stem cell and the myeloblast cells. Whereas the chronic forms, if you see both the chronic myeloid leukemia and the acute chronic lymphoblastic leukemia. If we see the chronic myeloid leukemia, we have seen the myeloid series, myeloblast gives rise to the monocyte and granulocyte. The acute form, it affected the myeloblast stage, whereas the chronic form, it affects the direct stem cells only. So the more of accumulation of hematopoietic stem cells along with myeloid stem cells are seen. Acute form, acute myeloid leukemia is affecting the myeloblast stage, whereas the chronic myeloid leukemia is affecting the stem cell and the myeloid stem cell, hematopoietic stem cells basically. When we see the chronic lymphocytic leukemia, acute lymphocytic leukemia, it's affecting the lymphoblast stage, whereas the chronic myelocytic leukemia, it's affecting the lymphocyte. So we have seen that lymphoblast differentiates into B lymphocyte and T lymphocyte. So the chronic lymphocytic leukemia, it affects the final cells that are nothing but the B lymphocytes. So more of accumulation of B lymphocytes are seen in chronic lymphocytic leukemia. Blood picture presents the accumulation of these cells only. Whatever stages they are affecting, accumulation of that cells or increased production of that cells gave rise to corresponding leukemia. So the common symptoms of leukemia include the generalized symptoms, that is the weight loss. Initially the patient presents the non-specific symptoms of the weight loss, fever, and the frequent occurrence of infections. And along with the symptoms of anemia like shortness of breath and chest pain are also present. The bones or joints, joint pain is seen along with weakness, malaise, and muscular weakness, fatigability when on small slight work, and psychologically you can see that patient has a loss of appetite, he gets fatigue easily even on showing slight physical exertion, he gets just dyspneic. And there is invariably there is enlargement of lymph nodes in leukemic disease. Whereas in anemia, that characteristic features like the fatigue, weight loss, fever may be present, but lymphadenopathy is not present. So here the characteristic of leukemia is the enlargement of the spleen and the lymph node. Along with that, appearance of skin lesions, that is the purplish spots on the skin, is more common. So these are the common symptoms of leukemia. Along with that, we'll see the oral manifestations. Before that, we'll just see the differences between the acute leukemia and the chronic leukemia. The acute leukemia, as I said, it is more common in the first and second decade of life. That is the younger children, younger adults or the children, whereas the chronic leukemia is more common in the older individuals or fourth or fifth decade in middle-aged adults. And the acute leukemia, it is very, very insidious in onset. Okay. Whereas the chronic leukemia, the patient has been suffering from the disease for decades, but he is apparently healthy. He doesn't know the symptoms of the disease. The characteristic feature or the symptom of acute leukemia is the presence of anemic features, that is the pallor or the fatigability, weakness, malaise, dyspnea. Along with that, infection, fever, and lymphadenopathy. Whereas the chronic leukemia, lymph node enlargement is seen, or pain in the abdomen, mass in the abdomen is more common. So the WBC counts in acute leukemia are reduced in number. They are about just 1 lakh cells per mm³, whereas the chronic leukemia, they are just moderately elevated. Whereas in acute leukemia, they are elevated to the levels of 1 lakh cells per mm³, whereas in chronic leukemia, they are elevated to more than 5 lakh cells per mm³. And characteristically, both the liver, spleen, and kidneys are enlarged. But in cases of chronic diseases, the chronic myeloid leukemia, it shows gross splenomegaly, which is just average when compared to the acute forms. And lymphadenopathy is more commonly seen in the chronic lymphocytic leukemia. As I have told you, chronic lymphocytic leukemia affects the differentiated cell, that is the B lymphocyte. Whereas all other forms, whether it be acute myeloid leukemia, acute lymphoid leukemia, or the chronic myeloid leukemia, these three are affecting the blast stages. Whereas the chronic lymphoid leukemia is affecting the site, that is the B lymphocyte. Okay, and the bone marrow, it shows the depression of erythroid cells or the erythrocytes, and chronic leukemia, it shows the increase of myeloid cells. If untreated, whatever be the disease, either acute or chronic, once it has developed, the survival rate of the patient is very, very less. Invariably, death results from respiratory arrest or because of organomegaly or leukemic infiltration of tissues. Death invariably results, but the survival rate is very, very less in case of acute leukemia. That is just 6 months. And you can see the blood pictures of the acute myeloid leukemia. As I told you, it affects the blast stages. The accumulation of myeloblasts are more common. Acute lymphoid leukemia, again it affects the blast stages, acute, so accumulation of lymphoblast stages or the stem cells may be seen. Chronic myeloid leukemia, again accumulation of lymphoblast or the stem cells more commonly. In chronic forms you see the accumulation of stem cells actually. Here it's the accumulation of lymphoblast stage, myeloblast stage. Thus the chronic lymphocyte leukemia, it shows the differentiated cell, that is the accumulation of B lymphocytes. Okay. So the oral manifestations. Now we have seen the generalized manifestations and the blood picture of leukemia. When we see the oral cavity, initially the commonest disease which affects the gingiva is nothing but the gingivitis. In cases of leukemia, due to leukemic infiltration of the tissues, deposition of increased white blood cells, they are just deposited in the oral cavity or tissues of oral cavity, and the gingivitis is soon progresses to gingival hyperplasia. Gingival hyperplasia is nothing but the gingiva becomes edematous, inflamed, and it's very enlarged. It covers almost all of the teeth. The gingiva becomes boggy, edematous. It is deep red in color. So gingivitis progresses to gingival hyperplasia, and ultimately hemorrhages occur. Hemorrhages are nothing but ulcerations of the oral mucosa and just frank hematomas occurring in the oral cavity. And along with that, there is increase in production of platelets. The petechiae are also deposited on the hard palate or oral mucosa, buccal mucosa plate. So because of this extreme gingival hyperplasia and necrotic ulcerations occurring, there is ultimate periodontal destruction. The teeth become mobile, loosen, and periodontitis occurs because of the destruction of the periodontal ligament. So here you can see in the clinical picture that the characteristic features of the gingival hyperplasia and the case of the acute myeloid leukemia showing the gingival hyperplasia along with the loss of teeth, how the gingival hyperplasia just covers the crown of all the teeth, and along with that the reddish purplish hemorrhages are seen. So just spontaneous bleeding of the gingiva is also seen here. So these are the oral manifestations involving the white blood cells. Leukemia is or blood cancer. It's a more serious form of disease, and as of now it is very severe, and the death rate is very high. Once affected, the individual has a very low survival rate. So now we'll see the diseases affecting the blood platelets or the thrombocytes. So again, the blood platelets, there will be either increased production of blood platelets or a decreased production. First we'll see the increased production or reduction in the red blood cells. Purpura. Purpura, what is purpura? Purpura is nothing but purplish discoloration of the skin or the mucous membrane. It is due to extravasation of blood in the skin or mucous membrane. Purpura is actually a commonest symptom seen in cases of diseases involving the platelets. So whenever you see purplic lesions in the skin or oral mucous membrane, you have to suspect underlying reduction or increase in the blood platelets, underlying deficiency of the platelets. So purpura may be of following type. There is a non-thrombocytopenic purpura. The non-thrombocytopenic purpura is the appearance of purplish discoloration of skin or mucous membrane which is not related to reduction in the blood platelets or the thrombocytes. So that is because of other infections and all. Thrombocytopenic purpura is purplish discoloration which is associated with the reduction in the thrombocytes or platelets. So thrombocytopenic purpura is of two types again, the primary or the essential purpura and the secondary or the symptomatic purpura. We'll see the primary or thrombocytopenic purpura. Thrombocytopenic purpura is nothing but reduction in the number of circulating blood platelets. Blood platelets are in the peripheral blood cells are reduced. That gives rise to this purplish discoloration. As you can see in the clinical picture, the extremity, the feet or the leg, it's showing the deposition of the discoloration. These are discolorations which are not raised above the skin surface. They are just deposited on the skin due to extravasation of blood from the capillaries. Okay, primary thrombocytopenia. It's a disease affecting the blood platelets. It's also known as Wellhoff disease. It's basically an autoimmune disorder leading to reduction in the blood platelets. Acute forms, acute thrombocytopenia, it affects the children, whereas the chronic form, it affects the adults. So the acute thrombocytopenic purpura is seen in cases of children, whereas the chronic thrombocytopenic purpura is seen in cases of adult individuals. So the characteristic features of diseases of blood platelets is the appearance of purpura. There is the purplish discoloration of the skin. So here also in thrombocytopenic purpura, you get to see the purplish discoloration of the skin, and oral cavity also shows the same purplish discoloration. And in oral cavity, you get to see the hematomas, appearance of hematomas in the oral cavity. It is nothing but deposition of blood here and there. And bleeding from the nose is more common. Along with that, bleeding of the gastrointestinal tract, bleeding of the urinary tract. Bleeding of the urinary tract is manifested as hematuria, whereas bleeding of gastrointestinal tract, it is manifested as melena or hematemesis, vomiting, chronic vomiting, that is called hematemesis, vomiting of blood, that is the hematemesis. Usually the spleen is not palpable in cases of thrombocytopenic purpura. That is the differentiating feature for this. And when you see the oral cavity, along with the appearance of purplish discoloration, you get to see the petechiae. Petechiae are nothing but pinpoint sized spots on the oral cavity. Pinpoint sized pink color spots on the oral cavity. They may be seen either on the lips, on the buccal mucosa, tongue, or the junction of the hard and soft palate. So along with petechiae, you get to see the hematomas. Hematomas are nothing but deposition of blood pigment. Excessive bleeding even from a soft gingivitis is seen. So here you can see in the clinical picture, these are nothing but the petechiae, purplish discolorations. Even in the lips, you can see the appearance of petechiae, oral petechiae. So the skin, the oral cavity, and the gastrointestinal tract and the urinary tract all shows the manifestations of bleeding symptoms to be diagnosed as thrombocytopenic purpura. Platelet count is actually about 60,000 per cubic millimeter. So the bleeding time is prolonged. So it takes long time for the platelet to aggregate. So the bleeding time is prolonged. Though there is no defect in coagulation, the fibrin threads are formed, the clot is formed, but the platelets take much, because there is a reduction in platelets, whenever there is an injury like that, the platelets are reduced in number. So reduced number of platelets leads to prolonged bleeding time. Whereas the coagulation time is normal because there is no defect in clotting factor as such. Both the RBC and WBC are normal. Treatment in severe cases includes nothing but the splenectomy has provided partial relief from all the symptoms. That's with the thrombocytopenic purpura. There is other purpura known as the thrombotic thrombocytopenic purpura. It's also known as Moschowitz disease. It is actually characterized by purpura along with microangiopathic hemolysis and presence of the thrombi in microcirculation. Thrombi are nothing but deposition of clots in the circulation, blood circulation. So the characteristic appearance of purpura along with the hemolysis and thrombi formation in the blood vessels gives this name thrombotic thrombocytopenic purpura. It is more common in females, and in cases of young individuals are more common. The characteristic features of thrombocytopenia are seen. Along with that, anemia, fever, and neurologic dysfunction and renal failure. So the thrombotic thrombocytopenic purpura is actually characterized by the thrombi formation in the blood vessels. So even the blood picture shows the presence of a thrombi. Wiskott-Aldrich Syndrome. Wiskott-Aldrich Syndrome, it's also known as the hypogammaglobulinemia. It's actually characterized by the reduction in immunoglobulin. Immunoglobulin deficiency syndrome, actually Wiskott-Aldrich syndrome is there. So IgM is deficient. IgM is deficient here. So it is presenting the characteristic appearance of clinical appearances of thrombocytopenic purpura along with eschema of the face. First initially face is involved, then it spreads to the trunk and extremities, and there is increased susceptibility to infection. Obviously the blood platelets are reduced, so the individual is more prone to get infections of oral cavity or generalized infections of the body. As I have also told that thrombotic purpura, whatever is there, it shows bleeding in the skin or oral mucous membrane, GIT, like that. And because the serum immunoglobulin IgM levels are low, infections are common. Malignant neoplasms like the lymphomas are more common in cases of this Wiskott-Aldrich syndrome. And because of reduction in platelets, spontaneous bleeding of the gingiva is seen. So the syndrome occurs when it shows the features of thrombocytopenic purpura along with the presence of lymphomas and immunoglobulin deficiency. So the blood picture, it shows that the IgM levels are low, though the other immunoglobulin, that is IgA and all, are normal in levels. Serum IgA levels, serum IgG levels, all are normal. Only the immunoglobulin M, IgM levels are very, very low. So the platelets are very reduced, that is about 18,000 to 80,000. So obviously when the platelets are reduced, the bleeding time is prolonged, and the characteristic feature is that the cells are different in shape. The cells show reduction in sizes and shape, that is nothing but the anisocytosis. So decreased production of platelet is the etiology behind this Wiskott-Aldrich syndrome. Okay. Now we'll see the other defect, other disturbance in the blood platelet, that is the thrombocytasthenia. Thrombocytasthenia is nothing but the qualitative defect of blood platelet. Till now we have seen the thrombocytopenic purpura. It is actually the quantitative defect, that is the reduction in number of blood cells. Reduction in number of blood platelets is nothing but the quantitative defect, whereas the thrombocytasthenia is nothing but the reduction in defect in the quality, that is, though the number may be now, it is nothing related to the number of platelets. The number of platelets may be reduced, may not be reduced, but there is a defect in the platelet, that is the platelet aggregation factor may be lost, the fibrin threads may not be present. So we'll see what is that. Familial thrombasthenia. Familial thrombasthenia is nothing but a qualitative defect in blood platelets which is transmitted to the other generations. Familial is nothing but transmission. So it is transmitted in a autosomal recessive pattern. So the individuals or siblings show effect of this disease, autosomal recessive disease, the thrombocytasthenia. Okay, siblings may be affected. The characteristic features, it is characterized by excessive bleeding either from the GIT, from the oral cavity, and from the urinary tract also, and the skin shows the purplish discoloration or purpuric hemorrhages. Then there is bleeding from the nose, from the GIT, and eventually bleeding is also seen into the joints. Bleeding is also seen into the joints. That is nothing but the hemarthrosis. Okay. So here, as I told you, thrombocytopenic purpura, the bleeding time was normal, bleeding time was prolonged, and the clotting time was normal. But here in thrombocytasthenia, because there is a qualitative defect in platelet aggregation factor, there is a bleeding time is prolonged, the platelet count is normal, but the clot retraction is impaired because of a loss of the aggregation factor or the failure of aggregation of platelets. Hemophilia. Hemophilia, it's also known as bleeder's disease or King's disease or the disease of the Habsburg. It's basically a hereditary disease. It is transmitted as a Mendelian recessive trait, that to X-linked recessive trait. Okay, this hereditary disorder, basically there's a defect in the coagulation factors. So that leads to this hemophilia. So what are the coagulation factors? There are hemophilia, it is of three types actually: hemophilia A, hemophilia B, hemophilia C. Hemophilia A, it is due to deficiency of anti-hemophilic globulin or the factor VIII. Hemophilia B, it is also known as the plasma deficiency of the plasma thromboplastin component, that is nothing but the factor IX deficiency. And hemophilia C is due to the deficiency of the plasma thromboplastin antecedent, that is nothing but the factor 11. So how actually hemophilia, it is X-linked recessive trait, right? So it is manifested only in males. Females are just the carriers of the disease. So the disease is clinically manifested in males, and it is transferred through carrier females to their sons. So hemophilia, what is the defect? The defect here is in the aggregation of the platelet. This is the normal blood flow. Okay, whenever there is a cut or an injury to the blood vessel, platelets get aggregated at that side, and the clot is formed. That clot leads to it's just a reaction of the injury. So here the clot, the factor 8 deficiency leads to disturbance in the clot formation. That invariably leads to prolonged coagulation time. That is the commonest feature in cases of hemophilia. We have seen the earlier diseases affecting the platelets. They had a prolonged bleeding time. Okay, here in hemophilia, it is a defect in the factor 8. So there is prolonged coagulation time. The bleeding time may remain normal here. So clinical manifestations are the hemorrhagic disease or this hemophilia. It is present from the birth, but the individual may not be clinically apparent of the disease until very long decade. So the disease itself is present from birth but manifested in later years of life. The commonest symptom for the hemorrhagic tendency is the hemophilia is the persistent bleeding. Persistent bleeding from the cut. Just a small cut leads to profuse bleeding of the fingers or any soft tissue like that. And there is hemorrhage. Hemorrhage is nothing but extravasation of blood or deposition of blood. Hemorrhage is noticed in the skin, in the subcutaneous tissue, even in the joints. The characteristic of hemophilia is a hemorrhage into the joints. So the child affected, even a minor trauma may lead to bruising of the skin and eventual hemorrhage of the skin. A massive hematomas are seen. So the injury may not be of such grade that it may lead to a hematoma, but minor bruising or cuts also lead to severe hemorrhagic response in cases of hemophilia. And coming to oral cavity, you see spontaneous gingival bleeding or appearance of gingival hemorrhage. Just a simple gingivitis may bleed heavily or profusely. And the occurrence of mandibular pseudotumor. Mandibular pseudotumor has been reported in many cases. That is nothing but a periosteal blood reaction followed by extravasation of blood. So these are the clinical features. Clinical features basically are the persistent bleeding, spontaneous in nature, hemorrhage into the joints, connective tissue, blood, and when coming to gingiva, it's the spontaneous gingival bleeding. So the disease affects the children, hemophilia. And when you see the blood picture, you see there is a deficiency of factor 8. So the bleeding time may be normal, but the coagulation time is prolonged. So there is a failure in the clot aggregation here. And the activated partial thromboplastin time is also prolonged. So there is no specific treatment for hemophilia as such. The person should be protected from getting injured or any form of trauma. It's just a preventive measure, and in case of hemophilia A, it is a deficiency of factor 8, so you can just transfuse whole blood or factor 8 to the patient can be given, and minor oral surgical procedures have to be avoided entirely, and when carried out, whole blood or plasma transfusion has to be given to this patient. And other common disease which is affecting the children is the von Willebrand's disease. Von Willebrand's disease, it is also a defect in the coagulation. It's also known by other names like pseudohemophilia or the vascular hemophilia. It is characterized by excessive bleeding in the patient, where the patients have the normal platelets and the normal clotting time, but still patients show excessive bleeding. Previous cases all were like there was either reduction in blood platelet counts leading to prolonged bleeding, either there was defect in some coagulation form leading to increased coagulation time. But von Willebrand's disease, It occurs due to deficiency of the von Willebrand factor. Von Willebrand factor is nothing but a carrier of factor 8. Factor 8, as we know, it's necessary for the clotting of the blood. Okay, clotting factor. Factor 8 is nothing but the clotting factor. And this von Willebrand factor is a carrier of the factor 8. So here patients have normal platelet count and normal clotting time. Actually, the defect is an abnormality, either a quantitative defect or a qualitative defect in the von Willebrand factor. So the clinical features. The clinical features are asymptomatic. Asymptomatic means the patient may not be able to realize that he is suffering from the disease, or there are no clinical manifestations, or it is usually seen when a patient undergo extraction of the tooth and it is just bleeding profusely and spontaneously and there is no clot formation. At that time only you get to notice this disease. Okay, and excessive bleeding following spontaneous trauma. The bleeding will be spontaneous, and minor trauma leads to extensive hemorrhages, and spontaneous nosebleed or epistaxis is common. Along with that, bleeding into the gastrointestinal tract is also common. If you see the pictures there, diagrammatic representation, we know that normally whenever there is injury to the blood vessels, the platelets are directed towards the surface, then the fibrin is deposited and the platelet aggregation factors are deposited and they just form a clot. But in case of von Willebrand deficiency, because of the deficiency of von Willebrand factor, factor 8 is not carried to the site of injury. So the platelets are just don't aggregate and there is no clot formation. So there is a qualitative defect in the clot formation here. So when you see the picture, peripheral blood picture or lab picture, diagnostic picture is of the bleeding time is prolonged, the prothrombin time is normal, the clot retraction is normal, only there is a defect in clot formation. Treatment includes the transfusion of plasma or anti-hemophilic factor. Coming to oral cavity, spontaneous gingival hemorrhages may be seen, which are extensive in nature, which are profusely bleeding, and appearance of hemorrhages which are seen on the gingiva or the buccal mucosa. And when coming to extraction in such patients have to be entirely avoided, and if carried out, it should be carried out by a tooth band extraction. Tooth band extraction is nothing but you just place a elastic band encircling the tooth and just push the band to the cervical area so that there is the necrosis of periodontal ligament. Eventually the tooth is loosened and it just exfoliated, and after tooth extraction also you have to put the patient on factor 8 or plasma factor 8. Okay, then transfusion of plasma and anti-hemophilic factor has to be, anti-hemophilic globulin has to be carried out. So care has to be taken to avoid trauma, because trauma is the one which induces the spontaneous bleeding here. So that's with the von Willebrand disease. Other common disease, it is also known as the parahemophilia. Parahemophilia, the name is confusing, and people confuse the name parahemophilia to hemophilia, but it is completely different. It is actually caused by a deficiency of this factor 5. We know the blood coagulation pathway. So there are a lot of factors helping in the resulting in the formation of ultimate clot. So the deficiency of factor 5 or proaxillary leads to inability to formation of thrombin. So this thrombin is not formed, so invariably blood is doesn't clot. So parahemophilia is transmitted as an autosomal recessive trait. Clinical manifestations include same as that of hemophilia. There is a severe bleeding tendencies, epistaxis, bleeding into the joint, hemorrhages, and formation of hematomas. The laboratory findings are the blood platelet is normal, the clotting time and prothrombin time both are prolonged. Though the bleeding time is normal, the clotting time and prothrombin time are prolonged, and the platelets are also normal in level. The treatments for any form of spontaneous bleeding, either due to platelet aggregation or due to defect in number of platelets, include the transfusion of plasma or frozen plasma. Freshly frozen plasma is just transfused to the patient, and in case of the deficiencies, care has to be taken to prevent any form of bleeding. And these are the diseases involving the blood platelets. There are other minor diseases like the afibrinogenemia. Afibrinogenemia is nothing but absent the deposition, there is not fibrin deposition is not seen in the blood platelets. That leads to a condition known as afibrinogenemia. Cryoglobulinemia is the deposition of proteins called the cryoglobulins in the blood platelets. These are just the minor diseases affecting the oral cavity.